My name is Kyle Baltrusch. I'm a board certified plastic surgeon in Portland at Portland Plastic Surgery Group. I always do immediate reconstruction. So I make myself available. I have block time scheduled with all of the breast surgeons that I work with. So it's not like, they're doing the procedure and then I will see them later at my convenience to do a delayed reconstruction. I feel like it's best to just do the reconstruction at the time of the lumpectomy or the mastectomy. But oftentimes, patients do see me for consultation without quite knowing all of the information yet. They might have a breast MRI pending or their genetic testing pending. And so those results can influence their decision with, what they want versus, a unilateral versus a bilateral or a lumpectomy or conservation therapy versus, a full mastectomy. So we usually talk through all of those options, but I do tell them by the time of the pre-op appointment, which is about 2 weeks before the surgery, I do need to know what we're doing so that I can order supplies accordingly. But typically by the pre-op, they have all of that information. But these patients, a lot of information is thrown at them so quickly. We want to make sure that we're dealing with their cancer, and so they're not just meeting with their breast surgeon. They might be meeting with a medical oncologist, a radiation oncologist, the plastic surgeon. The nice thing about my breast surgeons is they, reconstruction is always going to be an option for them. So they always talk about their reconstructive options and put them into my care in my office to talk about all their reconstructive options, the pros and cons of all of the different routes. But a lot of information is thrown at these patients very quickly. And we're expecting answers from them. And I do think that our job is just to, listen and tell them what their options are and make sure that they're making an autonomous decision for themselves in their reconstructive journey. I never want to feel like I'm leading the conversation one way or the other. I don't want to feel like I'm swaying a patient into making a decision. And so that is why, it's nice to sit down. Our consultations are an hour. Sometimes I have follow-up phone calls with patients that they have more questions. There is a lot of information to take in and that can influence these decisions for patients. And so that is why I think it's important for us to give patients all of the information with the different options, but also what that may look like moving forward, not just the immediate reconstruction, but what does that look like in 5 or 10 years from now? Oftentimes this is not just a one and done. There are future surgeries. Things can age differently with different surgeries. Some require radiation, some don't, and what that looks like for patients. There's a lot to take in other than just getting rid of the cancer. That is obviously the primary goal here. But from the reconstructive side, I think it's important that patients know what their options are, whether that be they want to conserve and do a lumpectomy. What can I offer them? That also means that they're likely going to require radiation and what that looks like for them long term. It's important to have these conversations. I want patients to feel very comfortable making this decision. And so making sure that they feel, understood and that they are understanding what you're telling them. The nice thing is, I work with, 3 amazing surgical oncologists who, do a great thorough workup with imaging and biopsies. And, so oftentimes patients do come to me knowing that they're either conservation candidate, meaning a lumpectomy, or if the recommendation is a mastectomy. And so it does help hone in my conversation about what their reconstructive options are with those. And so that might be just, breast reduction or breast lift on top of that if they're a good candidate, but discussing the effects of radiation. And then, with my mastectomy patients, unilateral versus bilateral and the pros and cons of that. And then, oftentimes, because I think it's most important to do all the soft tissue work ahead of time at the first stage, that I need to talk about, is there anything I can do as far as like a breast lift? Do I want to get the nipple areolar complex in a better position for my second stage reconstruction? So I think all of that should be done at the first stage. And so I want the implant to sit in a specific position. And so with that, I need to sometimes change the skin envelope around that and having that discussion with patients. So a mastectomy oftentimes is not just a straightforward, simple incision where you remove the glandular tissue. We need to do a little bit more work, and I need to have that discussion with patients. Ultimately, they know the procedures that I, do. We all do things a little bit differently. And so they've also honed in, what they recommend for patients and which surgeon might be a good fit for them of getting them to their reconstructive goals. But it's also a relationship, and it's a long, relationship. they know my personality. They know which patients might mesh well with me versus another plastic surgeon. And so they do refer them over to me accordingly. But yeah, this is like a long-term relationship. Oftentimes when patients are having reconstruction, whether that be, lumpectomy versus, and certainly with mastectomies and implant-based reconstruction, these are lifelong patients that I will want to check in every year or two because there are procedures moving forward that you have to have those conversations with. Implants are not a forever model. And so you're going to be meeting with these patients every year to 2 years. But ultimately, yes, those surgeons are referring them over to me to start that conversation. So immediate reconstruction is doing the reconstruction at the time of the mastectomy or the lumpectomy. Basically, the plastic surgeon is at the operating table with the surgical oncologist doing that reconstruction at that time. There are times that the surgical oncologist will act alone and do their portion of the procedure that we might want to confirm margins before moving forward with reconstruction. So it might be something that the surgical oncologist does their portion of the procedure. And then after the results, you're seeing the plastic surgeon to discuss a delayed reconstruction, which sometimes is just weeks later. That's what we mean by the difference of immediate and delayed. Immediate being at the time of the oncologist surgery, and delayed meaning later. We're there together the whole time. So we're side by side. We see the patient preoperatively together. Oftentimes I need to do a template or make the incision pattern for my surgical oncologist of how I want to reconstruct the breast. So I go in preoperatively and do all the markings. And then in the operating room, I'm assisting or preparing my reconstruction for when it's handed over to me. So I may be working on the contralateral breast in a bilateral procedure, or I may be prepping my tissue expanders on the back table, but we're in the room together the whole time during those immediate reconstructions. The surgical oncologist will certainly end before me, and so they typically don't need to stay during the reconstructive portion, but I will take over once they've done their cancer operation. So radiation, we typically see this with their conservation therapy patients. So lumpectomies, whether I'm doing like an oncoplastic breast lift or breast reduction to get patients to the size that they want to be after their reconstruction. So the reconstructed breast will be, radiated, and oftentimes that starts around 6 weeks postoperatively. And it can be anywhere from sometimes a single week, 3 weeks, upwards of 6 weeks. But radiation is damaging to the soft tissue. So it causes fibrosis or scarring. Oftentimes, if the farther you're out from surgery, you may not notice that you've had radiation as your tissues heal, but there's going to be changes long term. And sometimes those changes can occur over the course of 3 to 5 years. They're not immediate. The big one being atrophy. So atrophy meaning that there is, shrinkage or loss of some volume. So if we are doing a breast lift or breast reduction, I might make the breast that's going to be radiated maybe slightly bigger, knowing that after radiation, it's going to shrink a little bit. So it'll only improve that symmetry. And then, I think it's important to have that discussion of, patients still have to undergo imaging, whether that be 6 months or a year postoperatively for surveillance, and that it does make it more difficult to reconstruct a breast after radiation. We typically try to minimize surgery on a breast that's been radiated because of the damage to the lymphatic system, the blood supply, that they are more prone to wound healing complications or infections. And so I think patients need to know that going in, that if they ever required revisions or maybe a completion mastectomy, that there are increased risks after radiation, and that it also changes the expectations. So the breast will also age differently after radiation. So, you may look very symmetric at first, but radiation with that scarring or fibrosis of the soft tissues kind of locks that breast into place a little bit more. So the contralateral breast may age more naturally as those ligaments attenuate or stretch. And so there's going to be, more asymmetry as one ages, because the radiated breast is just not going to age as naturally as the other. And so I remind patients that, whether you're doing a unilateral procedure or you're doing different procedures on the breasts, or if one breast is going to be radiated, the best goal is probably volume symmetry in clothing, that things are going to look different if you're doing different things or if you're being radiated. So I think those are the expectations that patients need to know. Oftentimes, if patients are going to have a revision surgery, it's to the contralateral breast. So, and it might be just like a breast lift to get the nipples back into more of an alignment or get better volume symmetry, because we do try to minimize surgery on a radiated breast. The biggest risk, but we don't see this as common, is a patient who needs like a completion mastectomy or maybe develops a secondary breast cancer years later in the radiated breast. And then we're having that discussion of mastectomy, because with implant-based reconstruction, patients are more prone to capsular contracture with implant-based reconstruction after having radiation. And so you have to have those conversations and let patients know those expectations, because if they do fail implant-based reconstruction, whether that be for contracture or infection or healing problems, then you have to talk to them about using autologous tissue or their own tissue to potentially reconstruct the breast. It's not as common, but those are bigger surgeries and require, longer recovery. I see patients who have had their implants for, years, or they've had complications and they want to have that discussion of going aesthetically flat. And so that's, a discussion of basically talking about excising that radiated tissue and potentially just going with a flat closure. Again, this kind of goes back to the original consultation. And one of the first things I want to know are the patient's goals. So after reconstruction, are we talking, do you want to be smaller, like a B cup? Do you want to stay roughly the same size as what you are now? Or do you want to go bigger? And how do we accomplish that? I think ultimately, just because we're doing, breast cancer reconstruction, there are certainly options for patients for size goals. Patients have a choice in their size. And so the big thing is, how do we accomplish that? I have plenty of patients who are like, I want to be small. I want to be athletic looking. I want to be a B cup. And then, sizing is also subjective. So I often see patients who think that they're, a B, but I'm like, I think you're like a D. It depends on body habitus. It depends on where you're getting fitted. And so I think the best thing is, as I explain to patients how I interpret sizing, and so that we're on the same page. So this is how I see a C cup on someone. And to me, a C cup is just balanced or proportional to the rest of their body. You take into account their shoulders, their hips, their abdomens, and just how they feel balanced or proportional. This is that conversation that you have to have up front. And, I think it's also a nice thing about being a gay plastic surgeon, is I think women feel comfortable having those discussions with me, and that I don't feel threatening or paternalistic in those conversations. I'm not going to tell you what I think is best. And so I think women do feel comfortable telling me what their goals are with their reconstruction. How can I help get them to their goals, or what is realistic?